Shirley. I am really happy to be here, and I work really closely with Shirley and with Alyssa. We're really close colleagues, so it's a real honor to share the stage with them a little bit. And it's such a nice opportunity to meet people from all over San Diego. I'm maybe guessing that some of you are parents, but maybe not all of you are parents of kids with autism. So I'm just kind of thinking on this talk is going to be focused mostly to parents, but I'm more than open to hearing from anyone really, and any questions are a go. What I'm going to try to do is give you guys a little bit of a sense of how doctors think about the medications that we might use for a child with autism, and then turn it on its head and really focus on what you should be as parents feeling empowered to ask about, to know, and how do you make these kinds of decisions? Because the reality is these are really your decisions, and they're sometimes straightforward, but sometimes not so much. And our hope in the community is that parents feel really empowered to know what they can know about what kinds of things will help their kids, and feel like they can get the answers that they need if they don't feel like they know enough. So that's the stance I'm going to take in this. So it will start out with a little bit more of the boring background, but at least you'll see how we in medicine, how we start to think about things. So we train our doctors to learn about a little bit about the background about autism. And the reality is we probably don't do quite a good enough job. And we need people like Shirley out there helping to train doctors even more. But the background is that autism as a kind of different entity was talked about in our professional medical culture back in the 30s and 40s. And Leo Kanner was one of the first, not the first, but one of the first to really talk about autism as a discrete thing, as something that happens and has a syndrome, a combination of predictable patterns that we see in kids back in the mid 40s. And he wrote a paper called Autistic Disturbances of Affective Contact. And that the wording there draws from all kinds of previous wording, and it kind of means we notice in some kids that how they interact socially tends to be very isolative and not really about connecting. That's what that terminology kind of meant to him at the time. And the term autistic really came from other places. It described a type of behavior that some people with different types of mental health challenges had, where they would really be alone focused, not really about interacting with lots of people. So that's where the term became popularized. And he wrote about this extreme autistic aloneness, anxiously obsessive desire for the preservation of sameness. He started to notice these things in patterns of kids that he saw, and he wrote about them. And that's where these are the beginnings of what our medical community, and of course our parents and all of the community members that are dealing with autism began to learn about. All of these things in quotations are things that he and some of his later colleagues described as things that he saw. And this is very early on, so this doesn't really capture what we know now to be as this really rich kind of different way that that our youth with autism can present. One child may have all kinds of varied interests, and another child may have many fewer and many other types of challenges. So the uniqueness that our kids with autism have really cannot be understated. So following his work, Hans Asperger's kind of built on that, and hence the term, which you guys may or may not have heard, probably have heard of Asperger's, which really in today's world means someone who has autism of a mild type. So Hans Asperger wrote about these things also in the late 40s, and he took it from a little bit of a different stance. But one of the things I want to point out is this term, he wrote about autistic psychopathy. And this is an important thing to see, that our leaders in the field use terminology that's really kind of pejorative and has a negative feel to it. There's something behind this. I mean, what he's trying to describe is an aloneness and an application of a different way of seeing things. That kids with autism didn't seem to have the same type of sets of rules that they would operate by. But the term psychopathy doesn't really accurately describe it. And certainly today we know that the one thing has very little to do with the other. Psychopathy is about someone who doesn't believe in society's norms and can do really horrible things as a result. It just has nothing to do with kids with autism. But I bring it up. I like for our learning doctors to know about this, because it's important that they see that definitions of things change over time. And I think it's important for families to know that our understandings of autism really have developed. And if there are bits and pieces of things that feel judgmental or pejorative that are coming through, it's okay to call them out. It's okay to let people know about it. It's okay to educate your doctors, your providers, your colleagues, your friends about this, because this is an issue that we've had for a long time in our community. Which is not to say that Leo Kanner and Hans Asperger had any type of malintention. They really did a lot for helping us understand a lot of the range of experiences and ways of being that our kids with autism can have. So if you simplify a lot of that down, this is what our newest kind of diagnostic book, the book called the DSM-5. This is what it, I'm simplifying a bunch. This is what it says. Children who have autism will have persistent deficits in social and emotional reciprocity, some sort of deficit in nonverbal communication, some challenges with development and maintenance of friendships. In addition to that, restricted and repetitive interests and behaviors, which could look like insistence on sameness, some sensory interests or sensitivities. This word called stereotypies, which means repetitive kinds of behaviors that don't necessarily have a clear meaning to the outside eye, but are repetitive and are maybe perhaps to outsiders seem a little bit quirky. And then some other interests. Now, of course, you all know, but I repeat really at any venue that I talk about autism, that intellectual disability is something that may or may not be going on for a kid with autism. And that's really a talk for another day, but it's enough to say that kids with autism can be very sharp about many, many things, and they can have some challenges in some areas of figuring things out, whether it's numbers or reading or understanding how to interact with others. No one kid is going to be the same. So this graphic actually, I think I borrowed from Shirley way back in the day. And what I like to let our doctors, our learning doctors know is that at this point, there are, over the years, there have been many different ways to describe autism. And right now, what the state of our research is saying is that we probably think of autism as this spectrum. Shocker, you guys know that, but the spectrum of severity of symptoms, severity of presentation, that used to really be separated out into these different categories, where Asperger's syndrome was one thing and autistic syndrome was another. But that we should probably think about them as one larger way of being that has some biological causes but in the real world might look very different from one kid to the next. But we should try and think about them as the same type of underlying challenge. And that's helpful because it keeps us on the same path as far as how we try and help out. We try and use some of the same approaches, just modified. Same approaches for all kids who have autism, but modify those approaches to the kid. Okay, so this is another way to say the same thing. As you know, the prevalence of autism, the rate that the number of kids in any one community that have autism seems to be increasing, and we're not 100% sure why. But we do believe that there is a genetic component to autism, and there's lots and lots of studies that have gone into that. I'm not really an expert in that area, but we know very clearly that there are some genetic connections. So here's the meat of what we're going to talk about today, and I'll be sure to leave time for questions in the end. Why do medications matter, and when and how? So for some reason, I chose red to signify yes. I don't know why I did that. Really, it probably should have been green. But all of the red check marks let us know that it represents that there are medications that help with kids with autism who have these particular kinds of challenges. And this list is the list that I will give to a training psychiatrist to say, hey, these are the things that parents will come and ask you about. And so you need to be prepared to understand what types of things you can do to support kids and families who are faced with these challenges. So sleep, for sure we know that there's medications that help, and for sure we know that the first thing to do is really, first 5 or 6 things to do are non-medication interventions. Aggression. Aggression is probably the most common question that we get asked about, and it's actually one of the areas where medications can make the most difference. It's one of the areas where the stakes are highest. So we start to be dealing with medications that have higher potential side effects, and it can become a real challenge for families to weigh, okay, I got these side effects over here, but I have a child who is now a young adult, a young adolescent who weighs, I don't know, 80 kilograms. And when he gets aggressive, he really can hurt himself or somebody else. And I don't want that to happen. So that's kind of a scenario that I bring up to bring up the challenges that parents face. Self-injury, self-hitting, head-banging is another area where we get asked for support about. And the medication that we can use to help with this don't have a ton of supporting evidence. When I say supporting evidence, that's kind of a jargony way to say, one, have we tested it in conditions that are good conditions to test a medication? And what did the test show us? So have we done things like randomized controlled trials where we give thousands and thousands of kids across the country a medication, and we have social workers and family members and parents and doctors and the kids themselves all participate in these questionnaires before and after taking the medicine. What was it like? What was different? And then we'll give the same number of kids a medication that has a sugar pill in it instead of the medication itself, and we'll compare what do those kids, families, parents, social workers, what do they say? How do those results differ? That's evidence. That's evidence supported in the literature. You might hear that term from different doctors, and sometimes I feel like we forget to explain what that's about. But it's enough to say that the self-injury studies that we've done haven't been that many or that great. So sometimes it's worth it to try if the extent of the self-injury is pretty hard, pretty significant, but there's not a ton of literature, not a ton of studies. Impulsivity and running away, that's another thing that we deal with a lot, and there have been some studies that show that certain medications really help with the impulsive behaviors. Repetitive behaviors. Repetitive behaviors and the self-stimming behaviors kind of fall into this one category that for each kid could look really different, but things like, the various kinds of self-stimulating behaviors, different things. I had a kid who really needed kind of oral stimulation, and he would lick the walls for the variety of tastes and sensations that the painted wall would give. And we were all really worried about that because of ingesting. You don't want to ingest those things. That's not really safe. So we tried some medication to help with that, and it did work. There are a lot of studies that have gone into looking at this, and I have really we just came across a study this past year that looked at the real latest evidence on this, and there are a couple of medications that seem to be helpful for sure, and maybe some others that aren't so helpful. And then lastly, anxiety and depression. So anxiety and depression for kids with autism is actually quite common. And just like any kid, any school-age kid or any teenager, you can really be susceptible to these things. And we found that we have done studies on these things as well and found that medications in certain times can be helpful. So this is the list of things that I am often asked about. And I'll just add, as we talk for I'll probably do another 10 or so minutes on this, a little bit more detail about each one. And before I jump into the specific medications, I just want to drive home that anxiety and depression really are quite common for kids with autism. So 44% might have a specific phobia. Now, phobia is a thing that you don't necessarily need medications for. But my point is that you start to add these things up: phobias, major depression, separation anxiety, obsessive compulsive disorder. These are things that are somewhat common in our teenagers, but with autism, they're just a little bit more common. We're not 100% sure why that is, but we know that it can be true. So these kids really need to be afforded every support that they can be. And I'll talk a little bit more about how to think that through when you're talking about medication. So just in general, there's no one size that fits all. If we have two parents on this call with two kids with autism, there's a very good chance that one solution might work for one, but not for another. There's so many variables. There's language. How much language does the child have? There's the social emotional reciprocity. How much does the child need as far as interaction with peers, and how much are they getting? There are plenty of kids with autism who feel really isolated by some of the challenges that they have in building and connection friendships, building and connecting with friends and maintaining those friendships. And we know that one of the number one factors for developing anxiety and depressive disorders in teenagers is social rejection. So there's a lot of things for us to think about for each one of our kids. And as I'm trying to drive home, medication can be part of the puzzle, but the puzzles have so many pieces. So it's rare that I'll say, hey, this medication is going to fix everything that we're talking about today. And it's much more common than I say, look, this might play a role. Let's look at one area that this might help out, and let's see if it does, and let's monitor it. So it's so important to keep all of the other services and supports in place. And then the last thing about just generally thinking about this is ask about side effects and understand that in the end, it's as a parent, it's your right, your responsibility, your kind of burden, your really in the end, your decision to balance, to weigh these things out. That what are the side effects, and what is the possible helps? What are the possible benefits that I might get? And is it worth it to give it a try? And the doctor's role is really to help make sure you have all the information that they have and have a sense about what's the likelihood that you're going to get some of these benefits. Okay, so for sleep and repetitive behaviors, these are the two kind of quickest areas. Melatonin is probably the place that we start if, after doing all kinds of sleep hygiene efforts, you've continued to have real trouble with sleep. And we started at really low doses, so you can always ask your doctor about this. There are some other options for sure, but melatonin is probably the place to start. Okay. For some of those repetitive behaviors that I mentioned, the case that I gave was a child who would constantly try and lick the wall, but there's so many other examples. The most recent evidence says that these medications that I have listed here are the ones that are most common for to really help. That's interesting because a lot of kids with these behaviors will get tried on the antidepressants, and actually the antidepressants don't seem to help quite as much as these. And these medications, in particular, the antipsychotics and the divalproex or Depakote, those have side effects. They have side effects that you have to be really careful about. So the other two, the alpha agonists and the folinic acid, have many fewer side effects. So I would ask your doctor about those if you're interested in thinking about this. But the take-home message is really for these types of behaviors, probably behavioral interventions, understanding what's going on is the place to start. Okay, I'm driving through really fast, so I see that there are a lot of questions in the chat box, which I think is going to be the place where we get most of our kind of back and forth and most out of this. So I'll drive through this as quick as I can. Anxiety and depression. Anxiety and depression are so common, as I mentioned earlier. And if we've learned in the last 25 years from doing all these studies across the country that medications can help with anxiety and depression, and you really want to help because depression in particular is our biggest risk factor for suicide. And that really can no longer be a taboo issue in our communities because it's such a significant issue. Now, for all kids with anxiety and depression, I recommend therapy. And for kids with autism, depending on how much language they have or their type of language, there may be some limitations on that. So this is always a discussion with your doctor, but these are the three medications that we typically would start: sertraline, fluoxetine, and escitalopram. Now, what you see here on this slide is it's a breakdown for doctors. So it might not be incredibly helpful to you, or you might find it kind of interesting, as this could be some, if I'm thinking about something specific for my kid, I might want to know that I'm starting in the right ballpark. I think that the take-home point that I'll say is that no one of these medications is really better than the other. They each have some subtle differences, but for the most part, they've all shown to be effective to help with anxiety and depression. They all have the same types of side effects. No one is going to have really different side effects. Okay. I should say, as I'm looking at this slide, my goal today was to bring up these medication topics. But before medication, you really have to understand what's going on. So you would have to know that this kid really is dealing with a depression, and that can be complex. I don't spend a lot of time in this presentation talking about how to figure out if your child has anxiety, depression, but I'm happy to answer questions on that, and I think that is a really important part of working with your pediatrician or your teachers, and just as parents, talking with your kids about what kinds of things are going on for them as far as their mood. How are they feeling? Okay, I'm going to continue on. I mentioned that aggression is probably the area where our medications have maybe the biggest impact, but also really potentially significant side effects. So anytime there's some aggression going on for kids with autism, you've got to understand the bigger picture. And that really starts with talking with the parents. So what kinds of things have been happening lately? Are there stressors? Are there new things happening? Are there changes? One of the most important things to think about with aggression is there any medical problem that's happening? So stomach upset, tooth problems, dental problems. Some of the more common things that we see are in that area. Sometimes seizures can cause more aggression. So it's on the doctor and really the parent to work together to make sure that they're not missing something. I can tell you about a bunch of different times that I've worked with families who have said, what is happening? What is going on? Why is, my son all of a sudden doing these aggressive behaviors? And sometimes we discover that, oh my gosh, he was really, really, really constipated, or he's got a massive cavity back here and we just couldn't see it. So it's really on the team to look at those things first. We call that rule out. You have to rule out medical problems first because they can really be a common cause of aggressive behaviors. And then second to that, once you have had the medical problems ruled out, you want to get a sense of how severe is the aggression. So if it's really quite severe, then the doctor is probably going to be talking to you about an antipsychotic medication. Now it's called an antipsychotic, but we're not using it for psychosis in this situation. We're using it for aggression and irritability. There are a number of studies that have been done, just like the ones that I described to you. The RUP study, RUPP, is one of the largest ones, and that's one of the places where we get most of our information about whether these medications help. And basically, you see that they really can decrease the behaviors. So this slide is another example of kind of a doctor-friendly, but not a very layperson friendly and not a very family friendly slide. But the point is that this is Wanfacine falls into the alpha agonist category, and it's one of the medications we want for our doctors to offer families first. It's a medication that helps with impulsivity and aggression. It also helps with ADHD. And I've included in this some of my guidelines that I give to doctors about how to use it. Start it at low dose. Your maximum dose is going to be 4 milligrams. What kinds of things to watch out for as parents? Things like low blood pressure, headaches, falls. Clonidine is the other alpha agonist. This term, alpha agonism, basically we have terms that describe what is the medication doing in the brain. And alpha agonism means that this medication is activating a specific type of receptor called the alpha adrenergic receptor. Okay, you don't need to remember that. I'm just telling you some of the background here. So clonidine is really similar to guanfacine. It works in the same way. You have to use this lower dosing, but it has the same types of potential side effects. We're getting to the home stretch here. Risperdal is one of the 2 antipsychotics that we would use for the more severe type of aggression. And what I have here is actually straight from the FDA. This is what the FDA says this medication is approved for. So if you look at the bottom, it says irritability associated with autistic disorder. That's the actual terminology that the Food and Drug Administration uses to describe what this medication is approved for kids with autism. So this is what is out there in the literature, and these are the doses that they recommend. And really, my point is just I want our doctors to know this information to be able to say, look, yes, this medication is used for other things like schizophrenia, or that would be psychosis, but in this case, we're not using it for that. This is a different this is a different syndrome, a different type of a challenge that we're dealing with. Okay, and here's that RUP study that I mentioned to you guys. It's a study that has been going on for a long time, and it found that Risperdal was effective and well tolerated for the treatment of tantrums, aggression, or self-injurious behaviors in children with autistic disorder. So one important thing to keep in mind is this is the study. The study comes from all kinds of players, many stakeholders in one study. But it's not the FDA. The FDA is a government agency that's separate from this study. And so anytime that you are having a medication for a kid, especially one that has some side effects, you want to know, have there been any studies done? And what do those studies say? And you also want to acknowledge the FDA, the Food and Drug Administration, might not have approved this medication, but there still might be some studies that say it could be helpful and safe. So they're two separate kind of streams of to consider. Abilify or aripiprazole is the other medication that is approved for the same reason. And you can see again down there, irritability associated with autistic disorder in pediatric patients. It's really the same thing. The one thing I'll say about those antipsychotics is it's really important to watch out for the weight gain. Weight gain, which comes with potentially high blood sugar and high cholesterol, is one of the challenges that we deal with. And it usually goes away when you stop the medication, so that's good. But it's something that we have to be really cautious about. There are ways to treat it. There are ways to make sure that it doesn't progress, but you can't let it just continue to go on and on because it could just cause a lot of challenges. So that's just a comment about the antipsychotics. Okay, lastly, just to kind of summarize again in general terms, for medications, you may be thinking about for your own child, or you may be a professional wondering, okay, I work with a kid as a teacher, or I work with a kid as I don't know, an OT or something like that. Will a medication help this kid that I'm worried about with this problem? No one size fits all, so you can't know. But you can make sure that the parent has as much education as possible and is able to partner with the doctor to think about whether a medication might be worth trying. The medications really have some good evidence out there that they can help, and they really shouldn't be done in a vacuum. They should be done with other things in the works. So PT, OT, speech, therapy, school activities, extracurricular activities. Swimming is one that Shirley has taught me about that could be, a really nice activity for some kids with autism. So medications, I think, really are complementary to other ways to support our kids. And then this last bullet, I forgot to mention but I implied, if a child is on an antipsychotic for any one of these issues, they really need to be getting these blood tests at least twice a year. Okay, so that is all that I have. These are some references for those of you who are the type to read references at the end of the slide. And we have about 17 minutes to go through questions. I'm sorry, I should have left more time for that. But let's go right to the questions.
Okay, do you want me to kind of read them to you, Jason?
Sure, if you can, yeah, if you
Okay,
want to like
thank
choose
you. That
off
was
some ones.
terrific. So I'll try and summarize and I'll go back to the beginning where everybody, and keep writing your questions in the chat because I'll scroll down and get to them if we can. This was just a comment towards the beginning. You talked about, the checklist of things that medications would be considered for. Self-injury not being checked isn't surprising to me. It seems my child is highly reinforced by the self-injury. The psychiatrist has prescribed Prozac for this, but it hasn't helped at all. My child bites his hands and pinches himself. His hands are so callous now that his skin is like leather. So I guess her comment was back to you not checking at the beginning medications as that effective for self-injurious behavior. I don't know if you want to elaborate on that at all.
It's a great description of a really challenging situation. More often than not, I find that the SSRI, so Prozac is an SSRI, it's an antidepressant, don't help as much as you hoped for these self-injurious behaviors for kids with autism. Doesn't mean that it's necessarily the wrong place to start, because again, it has the fewest side effects. But for any case, I won't give you a recommendation about your case, because about your son, or yeah, your son, because that really is always a discussion with your own doctor. There are so many factors that need to be considered. But in general, if the first try at a medication hasn't really helped and the behaviors have gotten stronger, that's when I'm starting to think about either changing a medication or thinking about a medication that might be a little bit stronger. And so that if you look here at this page, the RUP study looks at that risperidone has some impact on the self-injurious behavior. Now, if you look deep into the study, I think the self-injurious behavior is probably a little bit less improved than the aggression, but that doesn't mean that we know how that would impact any one kid.
Can I make just one comment on that?
Of course,
just
please.
as that. So kids with a lot of self-injurious behavior, if it's not already been done, you might want to request a functional behavioral analysis, which you can request from the regional center, to really have somebody look at your child in various domains, home, school, and kind of really get a fresh set of eyes. It's called a behavioral assessment on a specific behavior. So in this case, it would be the repeated biting, rubbing of the hand that you described, and see if they can figure out triggers, kind of going back to what Dr. Schweitzer said, really kind of trying to figure out all the pieces of the puzzle. And medication may very well be part of that. And maybe it needs to be like you said, a different type of medication, but that is a service that's available to you. So if you've got specific challenging behaviors like the licking of the paint on the wall, you could have somebody come in and really evaluate what that is or is not doing for the child, and maybe identify some interventions that could be beneficial. Okay, next comment. I have a 20-year-old that has had his first psychotic episode 3 years ago, so at age 17, and was put on medication for the first time. It was so hard to get support as a psychiatrist who understands autism to treat on a medication level. I called Access in Crisis, got very little support. One psychiatrist, very little support, got one psychiatrist to help a year later, no longer going to take insurance. We no longer have psychiatry. Our son's nonverbal and they can't evaluate them. Rabies psychiatrists do not treat kids who are nonverbal. So much to say about the lack of help out there for people on the spectrum. He's seeing a Fred Finch team and has a temporary psychiatrist. So yeah, that's part of the wraparound program for Fred Finch. So just the story here is really about the challenges that you have getting psychiatry in a nonverbal, challenging situation to understand the needs and really help figure out what's going to work for the child. And unfortunately, your son, who's 20, and he's an adult now, is, it sounds like you've had a really hard time getting psychiatry. That's something our SmartCare team might be able to help you with if you want to call us on the parent line and ask for either myself, Shirley, or Alyssa, this is the kind of thing we do help people navigate. I might be able to help you with some ideas on that. So I'll put the slide for us up at the end here after we're done talking. You may have gotten it from before, but just give us a call and we'll try and see if we can help you identify some resources to help you with that. Okay? All is not lost. We're here for you.
And then let me just add.
Yes.
It's such a an important comment. It can be a real challenge to find not just a psychiatrist, but kind of a service that deals with acute situations, like any types of emergencies, that have the time, support, skill set, all those combinations of things to really get to know what a complex kid like your son really needs. It can be really, really hard and frustrating. And we're lucky that we have Shirley in our community. I think calling Shirley and Alyssa at SmartCare is a great luxury that we have, because you can really get kind of the most tailored services out there by talking with them. But it's still going to be hard to find emergency services that really know how to understand you. And that's just one of kind of the challenges that we have in our community, that our emergency services are so structured by the fact that mental well-being and mental health is separated out from medical health. And that just causes this like downstream of kind of like cascade of challenges. And one of them is that you don't have a lot of time when you're on an inpatient unit to get things together. So not a simple question. And I'm sorry that you had that experience at Rady. But it's a hard challenge to overcome. Talking with Shirley really can get, Shirley always has some great ideas about how to find.
I try.
How to
it's
find.
Not easy.
It's not easy, right?
Well, the other challenge is he's 20 now, so he's exited pediatric medicine. So now we're talking about adult psychiatry arena, because you're talking about a 20-year-old individual here. So yeah, there's some things that we can at least talk about, try and help you for sure.
And we just had a quick comment come in about who has access to SmartCare services. So it's a free program to everyone. So if you call in, you don't have to worry about what insurance you have. You can just call in and talk to us. It's a free service. We're based on grants. So feel free to call in. Don't let insurance be a barrier. We will work with you on your insurance to figure out which psychiatrist you can go to. So we can't guarantee that they will take your insurance, but we will work on finding you a resource list based on your insurance, but we are free.
And I will put the slide for SmartCare up at the end here, so you guys can take a photograph of it, or on your with your phone, or write it down. This was just a comment about Wanfacine. I think you've already addressed this, Dr. Schweitzer. My son is 7 with autism. He saw a psychiatrist about a month ago, gave us Wanfacine, but for the aggressiveness, but I do not know if this is safe for a kid, which I think you commented on.
Yeah, I think I answered that. It's Wanfacine is one of the alpha agonists. It's definitely safe for kids. Like any medication, you have to be on the right dose, so you can't be on high doses. 4 milligrams is the maximum, and it's specific. So if your child is having symptoms at that dose, it might be too high. I mean, side effect symptoms. So, but in general, it is a safe medication. And we're seeing.
Sorry,
I just wanted to stream together a couple of thoughts, because we don't have a ton of time here, but I'm seeing a couple of comments about, well, Wanfacine made my son tired. Clonidine made my son tired. This really drives home that each child is going to be different, and the side effects that each med has are basically, this could happen, but they don't happen for everyone. So I work with a number of kids who don't get tired from Wanfacine, but some that do. And one of the tricks that you can do with Wanfacine, and you can ask your psychiatrist about this, is you can split up the dosing, or you can also try the longer acting version of Wanfacine, which is called Intuniv. Those are some tricks that we use.
And the long-acting version of Clonidine is Cafe. So that's the other option on those. So this was just a comment. My guy's on a cocktail. He's 9 years old. Abilify, Wanfacine, Prozac. Not convinced it's the best. I'm just finding this information very helpful. So thank you, Dr. Schweitzer. Talked about being on a vegan diet and no longer has cholesterol issues, being on the antipsychotics for 4 years. And I think that's, to your point, Dr. Schweitzer, being mindful that antipsychotics can cause weight gain. So if they're helpful and the person needs to be on it, you've really got to aggressively manage weight issues with healthy diet, exercise, and the things you would do to minimize weight gain. That's the goal. So good for you for doing that. What's the likelihood that a child will taper off medication as they progress to adulthood versus taper off and rely on other therapies?
That's such a great question. I talk about that almost every day, and I feel kind of cheating that I'm saying, well, it depends on the kid. It depends on the kid. It depends on what we're talking about. But I have that conversation with every family that I try medication on. The one or two scenarios where I'm really not even entertaining that conversation. No, let me say that differently. There are one or two scenarios where I'm not initiating that conversation, is with schizophrenia that I'm convinced is for sure schizophrenia, and bipolar disorder, which I'm convinced is for sure bipolar disorder. Sometimes those diagnoses are given out and it's a maybe, because like everything with mental well-being, there's gray areas. But with schizophrenia and bipolar disorder, those medications they fall into a different ballpark. There are lots of things that we have to consider, and we're very, very hesitant to take adults off of those medications without some real serious thought, because it can be dangerous to do so. So that's a different scenario than what we're talking about generally today. And with most scenarios, what I'm bringing up with families is, let's give this 6 months. Let's figure out in 6 months where we're at and think about whether we can address your questions. If your questions are, I like to completely go off, fine, let's talk about that. If it's, I like to minimize, great, let's try that. There's always the caveat that if you do that, things might kind of come back. And there's parents often ask me, well, if things are coming back, doesn't that mean that the medication all it's doing is hiding the thing or the problem, the challenge? And that's not always the case. A lot of the challenges and symptoms that we target with medications are either periodic and they come back with or without medications, or they're things that are really part of, in the case of autism, part of the way that the child or young adult sees the world and or thinks about the world. And not that you're going to change most of that, but if there's an explosive, aggressive response that can be threatening to any time that you have a transition, that response is not something that necessarily will go away over time. Now you're going to want to do therapy and treatment and ABA or a full kind of diagnostic workup of what's going on. But a lot of these things, depression, anxiety, have that periodic comeback character to them. So again, I'm hesitant to say, yeah, you can just go off of these, but you should have the discussion.
Okay, my son has periodic, can you hear me?
Yeah.
Okay, my son has periodic limb movement disorder and autism level 2. Do we want to block dopamine in the brain or increase it? Would an anticonvulsant benzodiazepine be better than Risperdal? That's a hard one.
Who's asking that one? That one's a
that's like a med school question.
That's better. Yeah, so that's a great question. The reality is with that, you'll probably need to go beyond just the theory and try and see what helps, because what the challenge between dopamine and the things that go against dopamine is that it's all apples and oranges. It's all theoretical. I can't tell you how much Abilify will worsen the limb movements versus how much a dopamine agonist medication will help the movements, because the dosing of the medication and the way it actually works at the receptor sites are all really different. So I don't think I have a great answer to that other than you want to try things really cautiously. And the question, okay, I think I over understood I overinterpreted the question here. So with, yeah, you're really, I'm really hesitant to give you an answer here. This is more of a question that you're going to want to review with a neurologist.
Yeah, that's a neurology thing. Okay, I want to kind of, I don't want to, we're getting close on time here, so let's try and kind of touch on everybody's thoughts or comments. What are recommended meds for OCD behaviors? Taking so long to eat and making sure nothing goes to waste. He's licking his fingers, his plate, then he'll regurgitate the food into his spoon and back into his mouth.
Yeah, with those types of behaviors, you're really looking at two classes of medications. One would be the antidepressants. The antidepressants are the ones that really help with OCD behaviors. When it comes to food, if there is a behavior that's getting in the way of nourishment, I'm starting to think about an antipsychotic medication, and those can help with the antipsychotics are kind of secondary treatments for OCD behaviors when OCD behaviors become really severe. And they're also second line treatments for eating disorder behaviors when eating disorder behaviors become really severe. So in this kind of meeting of the two, I would think about that. But again, this is not something where I can give you a recommendation to try that with your son or daughter. Sorry. It's a question of having this conversation with your doctor, because there are a lot of factors that you have to explore with this to know whether either one of those can be the right medication.
Thank you. I work as a BCBA and I have a couple of clients currently on meds. Some of my clients' families tend to take their kids off the meds over the weekend as they are not in school, and they intend to give them a break from the meds. I always ask them to consult with the doctor about this, as I find myself concerned about consistency and how their bodies respond to on again, off again doses. What do you suggest parents with the mindset to basically give their kids a drug holiday on the weekends, school breaks, things like that?
Yeah, that's a great question. It's hard for you to know as not the doctor or not the nurse, because it depends on the medication. So with the stimulant medications, it's okay to take holidays, and that's a family choice. Sometimes it doesn't work as well, but it's okay to do it. That has to be a conversation between the doctor and not the teachers or other service providers might not be able to know which medication the kid is taking to be able to understand whether it's okay or not. Other medications is not good to do this with. So medications for depression or medications for aggression, impulsivity, ADHD, like the alpha agonists that I mentioned, it's not so good to do that. So it really comes back to make sure that you're talking with your doctor about whether this is okay.
What age can the doctor identify if my child has schizophrenia or suffers from schizophrenia?
There's no one specific age. The average age that we diagnose people is really much, much older. So we're talking between 18 and 25. And that in general, that's when schizophrenia emerges. So it's very, very rare for a teenager younger than that to be diagnosed with schizophrenia. And it's even more rare for a school-age kid to be diagnosed. It depends on what are the symptoms. And so I don't think I can give you much more than that.
And I think it's challenging in individuals who have communication disorders, because one of the characteristics of schizophrenia is sort of this atypical behaviors and might be saying things in a different kind of way. I mean, obviously, Dr. Schweitzer, you can elaborate on this. So I think it's difficult, and I think it's really difficult if someone's nonverbal to identify this. So it becomes really complicated in the autistic population as well to identify.
Absolutely. Yeah.
And then the other one was just similarly about bipolar disorder, what age? Probably the similar answer to that question as well. Okay.
Yes. Same answer.
I think we got through all the chats. So very good.
Great.
So on behalf of our team, we want to thank all of you for joining today, being engaged, asking really terrific questions. This is a really important topic. I have put up here for you the ways to reach us. Those of you that are parents or patients, call this number here, or you can email us, and Alyssa and/or I will reach out to you and try and help you navigate this somewhat complicated system. But our function with this program is to help get people connected to mental and behavioral health services. That can be therapists as well as mental health professionals such as psychiatrists. So that's what we do. And as Alyssa said earlier, there's no charge to you, it's free, and we're happy to help you with that. We will have the 5th session next week at the same time, 3 p.m. And next week, we're going to talk about sleep and autism, and hopefully I will put you to sleep. So we look forward to seeing all of you next week, and thank you for joining us.